Hi everyone, I'm Yiding from the Radiation Oncology Department of Baylor College of Medicine. Today I'm going to introduce our group's work using the AI-based synthetic simulation CT generation from the Diagnostic CT for simulation-free workflow of spinal palliative radiotherapy. I know, a lot of words here, and I will explain one by one what that means. So first let me introduce, briefly introduce the radiation therapy workflow. After the primary healthcare provider sends the patient to the radiology department, the patient will do the diagnostic image. For example, here is the patient doing the CT, so it's diagnostic CT. So for the tumor detection, diagnosis, and the stagings. And in this part, the patient positions as we call the diagnostic environment or diagnostic protocol, which is a balance between the accuracy and the speed. Then the diagnostic image will go to the radiology department for the treatment decisions, and the patient will come back to the radiation oncology department for doing the simulation CT, which will provide the reference data for the treatment planning. And at this part, the patient positions is using exactly the same environment and protocol that the patient will face in the further treatment. Then, based on the planning image, the radiologist, medical physicist will do the treatment planning. Then the radiation oncologist will approve the plan. Then the patient will receive the radiation therapy. So, as you can see, the middle part, the simulation CT is essentials, which is provide the accuracy dose delivery. However, it has some limitations. It needs a patient in-person visit, and it's caused time and labor intensive for our clinic. And because we need schedule the machine, we need align the schedule of the machine, and the patient is always cause delays. Sometimes it's weeks, very long time. So that brings up the questions: is that possible? We can skip this one to have the things we call simulation-free process that we can use the diagnostic CT not only for the treatment decision, but also for the treatment planning. However, now we have an issue here. When they use the different positions, when is the diagnostic positions, when is the treatment positions? First question you need to answer, how bad it could be. So this is the case for the spinal palliative radiotherapy patients. On your left hand, the first one is the simulation CT, and the second one is the diagnostic CT after the registration, and the red contouring is the target. For this case, is the spine. So you can see they have the misalignment, and you may ask, maybe you just do a very lazy or bad rigid registration. Then I export their spinal cord from these two images. The diagnostic CT is the blue, and the simulation CT is the red. The fact is very clear. These two curves cannot be overlapped via the rigid transformation. Why? Such spine position misalignment because they use a different protocols. For example, in the simulation CT, we use an immobilization device, and you cannot see such things for the diagnostic CT, and they will use a different pre-scan position alignment. Based on the spine position misalignment, another issue is, as you can see, the body bottom of the simulation CT is very flat. And compared to the diagnostic CT, the body bottom is curved. Why? This is because in the diagnostic CT, we use a curved culture to immobilize the patient, but in the simulation CT, because we already use the immobilization device, so the patient is laid on the flat couch. Based on the visualizations, we also extract the dosimetry matrix to compare the difference between the diagnostic CT and the simulation CT at the plan. The dosimetry matrix are the measurement to measure, to tell you like how much radiation that a patient received and how it distributes. So for this number, when it's close to 0, that means the two plane is more identical. And you can see, for example, like the V100, that's the difference is very large, 23.2%. And for all the other things, is at the boundary of the clinical tolerance, means it had a large fraction of the patient is over the clinical tolerance. How to solve this issue? Actually, the innovative resolutions we get it's surprisingly very easy, because I find both these problems, no matter the spinal positions or the body bottom, should have the diagnostic CT and the simulation CT on this part should have a very strong geometric correlations. Because for the spinal positions, the geometry is defined by the protocol, and for the body bottom, it's defined by the couch shape. It's just like if I have an image of my fist, then if I can identify the joint of my fist, then I can predict what it looks like when I expand, when I relax my hand. So based on this one, we do the AI-based geometric corrections with the 2 steps. First step is do the spinal position corrections. And instead of using absolute positions of the spinal cord, we use the relative positions between the center of hurt to the spinal cord to get relative distance through a neural network to expect what this relative distance will look like in the simulation CT. Then we can get the AI-generated shift. And step 2 for the body bottoms, after the spinal positions, then the spinal position of the DCT and the diagnostic CT and the simulation CT should be overlapped. Then with the center of spinal cord, I can get a relative distance between the center of spinal cord to the body bottom. Then also go through a neural network. I can expect what it will look like for the simulation CT. This is the result, shows the result of our AI-based spinal position corrections. The blue one is a diagnostic CT spinal cord. The red one is a simulation CT, and the green one, I know it's rare to see because they're overlapping so well. The green one is a diagnostic CT with the AI corrections. And this one is for the body bottom corrections. The blue one is diagnostic CT. The cyan one is after the diagnostic CT, after the spinal position corrections. The red one is simulation CT, and the green one is with the AI corrections. So this table shows how the AI applied on clinical test data. The first column is a simulation CT. The second column is a diagnostic CT. So as you can see here, 2 problems. One is the spinal position. One is the body shape. And the last column is our AI corrected method. In our field, we call synthetic simulation CT. So both of the issue, the spinal position and the flat body bottom, be solved. And then I compare the dosimetry features with the AI corrections and without the AI corrections. So for the dosimetry features, as I introduced before, when it's close to 0, it will be better. The higher, that means the plans are different more. We test in two clinics. One is in our safety net clinic. It's a Harris Health Smith clinic. As you can see, all the dosimetry features are much smaller than the with the AI correction is smaller than without the AI correction. And then the second one we test in our academic medical center, Baylor St. Luke's. So also all the dosimetry metrics are smaller. And for the Smith clinic, almost all the dosimetry metrics you can see a statistically significant decrease. And for the Baylor St. Luke's, only one dosimetry matrix shows such large decrease. In addition, we also ask 4 physicians to do independently blind scoring for the diagnostic CT as a planning CT with and without AI corrections, same for both clinic environment. And for the Smith clinic, all the physicians' observations shows a significant agreement than with the AI corrections, the planning CT performance better. And in the Baylor St. Luke's, half of the 50% of the physician observation shows a significant difference between with and without the AI correction. So what the research tells us? First, our AI-based spinal positions and body bottom corrections can improve the diagnostic CT plan accuracy at both the Smith Clinic and the St. Luke's. However, as I introduced, the improvement in the safety net environment is more significant than in the academic medical center. Why? This is because in the academic medical center, it has more stringent pre-scan alignment protocol. What that mean? That means in the academic medical center, the technicians spend more time to align the patient positions. So use my fist example to say, if this one, from the fist to extend the hand is Smith Clinic, and for the Baylor St. Luke, it's more like my hand is already relaxed, then I predicted what it looks like when extended. The difference, the geometric difference between these two cases are very different. However, such difference also give us potentials to reduce the gap for the simulation-free process in the resource limited settings compared to the academic medical center. Our group's future work, further work, including first explore the softer tissue delineations and autonomy changes, especially for the small tissues. And for our simulation-free process, as a Baylor St. Luke's, we submit a protocol of the brain SBRT, and we hope we can treat soon. And then another things I thought we introduced before is because the simulation image, they have the immobilization device. So our group is working on using the 3D printing technology to get the immobilization device like a mask based on the diagnostic image. Thank you very much.
All right. So did you need AI to do this, or was it just easier because you had AI?
Well,
it's just a translation, right?
You get the geometric alignment based on the protocol. If you don't use AI, you need way more large data sets to statistically expect it. What's the correlation between them? With the AI, you can do it in 20, 40 patients. And this workflow, if you apply it to a new clinic, because different clinics have a different protocol. If you have a pre-trained AI models, you need additional like a 4 and a 5 in this clinical, then they can fine-tune to a new AI model for your specific clinical. But if you're doing a statistical way to do that, then you need like additional 100 history patients to expect what it looks like.
Okay, thank you.